The Curbsiders podcast is for entertainment, education, and information purposes only. The topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Memorial Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we are responsible if you screw up. You should always do your own homework and let us know if they were.
Welcome back to the Curbsiders. On tonight's show, Paul, we will be discussing some hotcakes. And Paul, guess what? This is coming on Thanksgiving, so you know what that means. This is, what are we going to call this? Hot tofurkey cakes? Is that what we settled on?
I don't think I agreed to any of that, no.
All right, well, if I haven't said it yet, this is the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend, Dr. Paul Nelson Williams. And Paul, hotcakes, you want to tell people what that is and then remind them what this show generally is?
Sure. Yeah, no, the hotcakes is where we and our expert team review practice-changing articles that have come out or sort of tickled our fancy or that we think might have some educational value to them. And luckily, we've brought a bunch of ringers in that are very smart that will sort of talk us through the articles and how we should think about them, or at least how they think about them. As a reminder, when we're not doing that during other episodes, we're always the internal medicine podcast, no matter what we're doing. Typically, we use expert interviews to bring you clinical pearls and practice-changing knowledge. But as you mentioned, this is one of the rare instances where tonight we are the experts. The experts are us. More so, the gigantic team we have assembled here, not just the two of us, Matt.
I guess I should say who's here up front, just because they may hear voices before people present their articles. So with us, we have three great guest hosts and presenters who will be talking through some articles. Dr. Ira Kryzhanovskaya, who you may know from the Curbsiders Teach podcast, one of the two co-hosts there. Dr. Nora Taranto, who is the editor of the digest where most of these articles have been featured, and Dr. Rahul Ganatra, who is our resident, Paul, are we calling Rahul a whiz kid in epidemiology or critical appraisal? Critical appraisal, yeah.
Critical appraisal whiz
I would
kid,
say
I think
that's
it's
fair.
right. Yeah, that feels correct. This show is sponsored by BetterHelp. Navigating life's challenges can make you feel unsure, and it's a time of change for a lot of people. I think the past couple of years have prompted a lot of us to sort of reevaluate things and try something new. And as we sort of face the challenges that come along with that, it's normal to feel stuck because, unfortunately, life doesn't come with a user's manual, and it's hard to know how to correct certain behaviors and how to process thoughts, sometimes without a little bit of help. And therapists are trained to do that. They can help you figure out the cause of challenging emotions and learn productive coping skills. BetterHelp has connected over 3 million people with licensed therapists. It's convenient and accessible anywhere, and it's 100% online. I'll say it every single time. It's a stressful time, and therapy can help you learn coping skills. It can sort of help you identify how you respond to emotions and can help you maybe develop more productive behaviors to help you move forward as opposed to feel like you're running in place. As the world's largest therapy service, BetterHelp has matched 3 million people with professionally licensed and vetted therapists available 100% online. Plus, it's affordable. You just fill out a brief questionnaire to match with a therapist, and if things aren't clicking, you can easily switch to a new therapist anytime. It couldn't be simpler. No waiting rooms, no traffic, no endless searching for the right therapist. Learn more and save 10% off your first month at betterhelp.com/curb. That's BetterHelp, HELP.com/curb.
Ira, so first up, you have an article, and if you want to tell us at least the first author and the name of the article, and then let's get some top line results and start the discussion.
You got it, Matt. So this is by Dos Santos and colleagues. This is the Association of the Weekend Warrior and Other Leisure Time Physical Activity Patterns with All-Cause and Cause-Specific Mortality, a nationwide cohort study. This was published in JAMA IM this summer. And their question was, does performing the recommended levels of weekly physical activity in 1 to 2 sessions, labeled Weekend Warrior, versus 3 or more sessions, labeled as regularly active participants, influence mortality? Now, this trial riffs off of the 2020 WHO published physical activity guidelines, which, if you're like me, were like, what is that again? Like, I probably should know that. But basically, adults are supposed to do 150 to 300 minutes of moderate activity or 75 to 150 of vigorous activity per week. And the gap in the literature here was it wasn't clear if reaching those recommended WHO guidelines in a concentrated way had different health implications than reaching them in a spread out way throughout the week, because there's feasibility implications to doing that concentrated physical activity. And they use the term weekend warriors, but I think it's just because it sounds great, because honestly, doing physical activity on Tuesday and Wednesday in that concentrated time is the same as doing them on Saturday and Sunday. So it doesn't have to be the weekend. So no worries if people's weekend is actually their Tuesday, Wednesday.
I like to see some smart branding from a journal, or from the article's author. That's good.
Right?
Good on
Like
them.
Tuesday is the new Saturday, or and Wednesday is the new Sunday.
Yeah.
And so they hadn't, all this trial also hadn't kind of hit that gap yet of the frequency of physical activity and the total volume of physical activity that was needed. That hadn't been evaluated fully in the literature. So this was a prospective cohort study including 300,000 adults and their self-reported physical activity via the U.S. National Health Interview Survey from 1997 to 2013. And their data was linked to the National Death Index through December of 2015. And in terms of the comparison groups, their comparisons were participants by self-reported activity level. So for those folks who were physically inactive, less than 150 minutes per week of moderate to vigorous physical activity, or physically active, greater than 150 minutes of moderate, or greater than 175 of vigorous activity. And again, they also looked at intensity and volume and compared that to all-cause mortality, cardiovascular mortality, cancer mortality. And they only had access to death as reported in that National Death Index, and so major causes of death only. Now, punchline, Matt, were you going to say something?
That's what I was going to ask. I was like, so let's get the top line results and then we can dig in a little more, get under the hood of this a little bit more.
Yes. So top line results, when we compare to people who didn't exercise at all active groups had less mortality, which is like winning, right? But there was similar mortality outcomes for weekend warriors and regularly active participants. So again, this is good news for folks who are planning to exercise on 1 to 2 days. And they looked at this again as hazard ratios for all-cause mortality for weekend warriors being 0.92 and for regularly active participants 0.85. And so the bottom line for this, if people are asking, kind of, I think about it as exercise is mortality reducing. So it doesn't matter if you're doing it frequently in small aliquots or similar amounts, but in concentrated 1 to 2 day period, which might be easier to fit in for some folks given their schedule. Really, exercise is beneficial to health and to chronic disease. So really just a welcoming feature for those of us who do concentrated physical activity.
So essentially, if you hit the 150 minutes a week of moderate or 75 minutes a week of vigorous activity, there's benefit to you, regardless of whether or not it's happening quicker. And Ira, now I know you spoke with one of the authors of this trial, so we're going to get to that. But it basically sounds like if I exercise 150 minutes a week moderately or 75 minutes a week vigorously, I should be good for reaping some mortality benefits. I want to go to Rahul here and say, Rahul, did you, the design of this trial, any sources of chance, bias, what do you think about the power, those smart things that you talk about when you're appraising an article? Help us out.
So this study, fascinating read, Era. Thank you for giving me an excuse to read this. I'd been hearing about this, but hadn't read it yet. So I was pleased to have an opportunity to dive in. So this study was really had a couple interesting features about it and some good learning opportunities for us in critical appraisal of the literature. I will just telegraph my final thoughts now by saying that there was nothing that really, threatened the conclusions of the paper in my mind. And I would welcome if, listeners have observed things that maybe I've missed, which happens all the time, please, message us and, tweet at us, because critical appraisal kind of works best as a team sport. So there were 2 or 3 things that I thought were worth mentioning. So this study was a prospective cohort study. And so that means that the comparison groups were defined by the exposure. In this case, the regular physical activity or the weekend warrior pattern, as Era discussed. There was one source that I could identify towards biasing towards an underestimate of the relationship between those exposures and the outcome of mortality, and that was the definition of people who were physically inactive. We're talking a little bit ahead of time that that still included people who were exercising up to, I think, 149 minutes a week. So that is definitely going to include some people who are reaping the benefits of physical activity below the recommended levels in the control group. So that's likely to bias away from the association with either activity pattern and a reduction in mortality. And then another cool thing about this study was the way that the authors attempted to address a problem called reverse causality. And this is where rather than the exposure leading to the outcome leads to the exposure. And this is kind of an interesting problem that, it's good to be aware of and be on the lookout for. And the way that the authors attempted to deal with this was they excluded people with chronic disease at baseline. And the thought here was that if people with, chronic disease that might limit their mobility are included, maybe it is the reality that their chronic diseases is what leads to cardiovascular morbidity and mortality, not their activity pattern. So their kind of plan for dealing with that is excluding those people. There are downsides to that, but that's one strategy. And then the other thing that they did was they also excluded the first 2 years of follow-up. And the reason for that is that you need time for exercise and physical activity to kind of exert its benefit and affect your mortality from cardiovascular causes. So a couple good strengths of this paper. And then I'll also point out that residual confounding is always a concern we have to be vigilant for in any observational research. And in this study, there's a nice example of residual confounding by the total amount of moderate to vigorous physical activity. And you can see that in Table 2, where the authors show the outcomes for each of the 3 exposure groups: people who are inactive, people who are weekend warriors, and people who are regularly active. And you can see that the hazard ratios for the regularly active folks were all suggested a reduction in all-cause mortality, cardiovascular mortality, and cancer mortality, but we don't see that same reduction for weekend warriors. So that's because these observations are confounded by the total amount of moderate to vigorous physical activity. And in the sort of final model where the authors did control for the amount of physical activity people were getting, we see that difference disappears. So I interpret these results as, if people are able to perform the recommended amount of physical activity, not, with any regard to how it's spread throughout the week, whether it's regular throughout the week or if it's concentrated on 1 or 2 days, that this evidence suggests that those people still derive the same mortality reductions. So exciting study, relevant to a lot of people I know in internal medicine, and particularly the residents I work with.
Ira, what did the author you spoke with, did he have any other additional insights or things you wanted to share with the audience?
Thanks, Matt. And thank you, Rahul. Yeah, Dr. Leandra Rosendi definitely highlighted exactly what you mentioned, Rahul, about making sure that the participants were healthy at baseline, that was the kind of the comparison that they needed going forward. And I asked him about kind of the generalizability of this trial, given that the study population was so healthy, and he definitely suggested that it's generalizable for this population, and it's also, plausible to assume that the benefits of the weekend warrior or other patterns of physical activity, as long as you're meeting that time recommendation, is applicable to other populations as well. So he was just really excited that in his epidemiology world that we're seeing kind of the benefits of exercise and by type as well. And some of his group's work has been published in Circulation as well, and looking at the types of exercise, and that, the more you get, the better it is. And I think that's another kind of bottom line punchline for us with this trial, is just remembering that exercise is healthy and so beneficial. And if you can only do it in 2 sessions, then that's great. It still works.
And I saw another article talking about like resistance training at least twice a week, and that or muscle strengthening activities, essentially resistance training, also seems like it has a mortality benefit, and this was in patients older than 65. So it is exciting to see this kind of stuff out there. Hopefully we can convince people to do it or figure out ways to fit it into their life. But I guess the weekend warrior, this 1 or 2 sessions a week pattern, makes it easier. Paul, are you a weekend warrior?
I don't know how to answer that. I also exercise during the week too, so I will say no.
I've seen Paul.
I thought you were
trail
going to get a
those
question, so
days.
that's why I asked it. Yeah.
Paul's, But a
Yeah, I'm a
Tuesday,
lover, not a
Wednesday
runner.
warrior.
Yep.
All right. Well, we have to move on. Rahul, I know you have an article to talk about. This Paul, this one's called the Waterfall Trial. I don't know if there's an acronym crammed into that, or they just like nicknamed it the Waterfall Trial. Is that an acronym, Rahul?
I don't think that this is an acronym. I think the authors were just big TLC fans and wanted to, work a popular song title into the study.
So, how about you tell us the author, the name of the trial, and let's get into some of the the top line results here.
Yes, it would be my pleasure. So this study is by Dr. D. Madaria and colleagues from the ERICA Consortium. And as you mentioned, it's called the Waterfall Trial. This is aggressive or moderate fluid resuscitation in acute pancreatitis. And it appears in a September issue of the New England Journal of Medicine. And this paper asks the question, which is a more effective and safe fluid resuscitation strategy in acute pancreatitis? Really aggressive resuscitation, and I'll define that in just a moment, or kind of more restrained, moderate resuscitation depending on volume status. So the hypothesis has been for many years that regional pancreatic hypoperfusion in pancreatitis is what leads to necrosis and other local complications. And it's been thought from animal studies that this could be mitigated with really aggressive volume resuscitation. And on that basis, professional society guidelines recommend aggressive fluid resuscitations for patients hospitalized with acute pancreatitis. But the human evidence base is overall quite weak. And so these authors designed a randomized controlled trial to test the hypothesis that aggressive fluid resuscitation would be different from moderate fluid resuscitation. And patients were randomized in an open label fashion to either aggressive IV fluid resuscitation, which was a bolus of 20 mg per kg, followed by a continuous infusion of 3 mils per kg per hour, or moderate IV fluid resuscitation. And this was a bolus of 10 mg per kg, so half, but only if patients were hypovolemic, followed by a continuous rate of half of the aggressive group, so 1.5 mils per kg per hour. And fluids were stopped once patients were eating, and this could be as early as 20 hours in the moderate group and 48 hours in the aggressive group. So now that you know all that, the top line findings, this was a negative study. It was stopped early by the Data Safety Monitoring Board due to evidence of harm with regard to the primary outcome, which I'll tell you it is in just a moment, without any evidence of efficacy. So the primary outcome was a composite that reflects the development of moderate to severe pancreatitis during the hospitalization. And this was the development of either local complications, exacerbation of other underlying diseases, a creatinine elevation above 1.9, hypotension, or a reduced P to F ratio. That primary outcome, so a composite of bad things, occurred in 22% of patients randomized to the aggressive group and only 17% of patients randomized to the moderate group. So no difference in the primary outcome, but the primary safety outcome, which was volume overload, and this was diagnosed by symptoms, signs, or imaging findings. This happened in 21% of patients randomized to the aggressive group and versus only 6% of patients randomized to the moderate resuscitation group.
Paul, does it seem to you like we've just been like wrong about everything about pancreatitis, like feeding, fluids, like the two main things that we were always taught?
100%. We're dating ourselves, but I think we both trained during the time of bowel rest for pancreatitis. You'll recall, and then now this, and it was always don't feed them and then just dump as much fluid as they can possibly tolerate into them because of fluid shifts and other sort of nebulous reasons. So this is sorry, prior patients.
I did think that there were some things, we talked about this trial. I think there were maybe some things that biased towards the safety outcome being more likely in like one group than the other, because I just noticed that the fluid resuscitation could be stopped much earlier, like at 20 hours in the moderate group, and had to be continued for 48 hours in the more aggressive resuscitation group. So that seemed like it would have maybe pushed more patients towards volume overload. And then since it was open labeled, like if you're treating that person, they're getting aggressive fluids, maybe you're more likely to pay attention to like their fluid status, is what I was thinking.
Yes, totally. I think those are key observations. And, for any study, we've used on the show a framework quite often of kind of conceptualizing, is this a positive study or a negative study? it's a little arbitrary, but with respect to the primary efficacy outcome, you could call this a negative study because there was really no difference between the aggressive strategy and the moderate resuscitation strategy. So then that clues me in to look for sources of that being a false negative. I'm not really finding any. You might wonder if the study was stopped early. Could this have been underpowered for the primary efficacy outcome? I'm actually not concerned for the study being underpowered because the point estimates actually suggested a higher incidence of the bad primary outcome in the aggressive group. And the confidence interval in a study that's underpowered is wide and just crosses unity, and you kind of wonder if we had more people with the narrower confidence interval achieve significance. I don't think that would be the case here. I mean, the limited data they had from the patients who were enrolled suggested that they really was no benefit of aggressive resuscitation. And then for the safety outcome, I think you hit the nail on the head that the open label nature of this study probably did clue in assessors to kind of look for signs of volume overload. It's a pretty big difference. So that does make me kind of think that, even if there is some ascertainment bias in the rates of the outcome of volume overload, that based on what the specific outcomes actually were, that probably does represent a real signal. I would like to apologize to all the patients and trainees who I have, told aggressive resuscitation is the way to go, because I really think that this article provides really strong, compelling evidence that there is not really much benefit to flooding people. So I think that in the tofurkey season, this gets 5 hot tofurkey cakes for me. I think this is ready to change practice. Yep.
That is fantastic. And thank you for your tofurkey cakes rating. Actually, we forgot to ask Ira for her rating of the Weekend Warrior article, which I think we must get. Ira, so it's on a scale of 0 to 5. 5 is practice changing. And then, 0 is this, no one should even read this. So that's the scale we're dealing with here.
Wow, that's hard, Matt. I mean, I am somewhere between a 4 and a 5. I think this, for the folks who I can share this, patients specifically, who can only get 1 or 2 sessions of moderate to vigorous physical activity, this is going to be a game changer. I'm going to recommend this to them and tell them that in terms of mortality, things are about the same, whether it's Tuesday, Wednesday, or Monday through Friday.
So it's not
right, so
2 hotcakes or 5 hotcakes.
It's 100.
5 hotcakes.
Yeah,
It's 100 and 0 and
151 hotcakes. Oh, and the cat goes on the chair.
Yeah, I mean, this
Always
is the dream of recording with video, Paul, because now people can see the cat, which this happens every time we record a podcast. I believe that's Ollie is on the chair with Paul. All right, Paul, tell us about the sprint trial. We covered this, Paul. You and I mean, I feel like this is really the start of our podcasting relationship anyway. We had known each other for quite a long time.
Yeah.
Sprint trial, episode number 2 of the Curbsiders. And now this is going to be episode number 400 something,
Bananas.
which is sad in some ways. But
Right.
we're revisiting the sprint trial, Paul. So tell us about it.
No. As we march towards death, I think it's important to sort of re-examine things, and that includes the sprint trial.
This episode is brought to you by Birch Living. Folks, I have some hobbies. I like a good book. I like to cook a good meal. I like to eat a good meal. I like running, but there is nothing in this world that I like more than sleeping. It is, without question, my favorite thing to do on this planet. And that's why I'm so grateful to have a Birch mattress that allows me to get a quality good night's sleep. Birch mattresses are stylish, they're comfortable, and they are environmentally conscious. I want to give all of our listeners the ability to enjoy a deep and restful night's sleep with a new mattress from Birch. They source only the finest quality materials like organic fair trade cotton, organic wool, and natural latex to create luxurious mattresses designed to give you the best night's sleep. Every Birch mattress is constructed with non-toxic materials and a focus on breathability to keep you cool at night. Plus, Birch knows there's no better way to test out a new mattress than by sleeping on it in your own home. That's why they offer a 100-night risk-free trial. Try out your new Birch mattress, see how your body adjusts, and if you decide it's not the best fit, you're welcome to return it for a full refund. Birch mattresses are shipped directly from their manufacturing facility to your door for free. The mattress comes rolled up in a box. It is super easy to set up. Birch is giving $400 off all mattresses and 2 free EcoRest pillows at birchliving.com/curb. Again, that is $400 off and 2 free EcoRest pillows at birchliving.com/curb. Sleep better with Birch.
So this is an update to the SPRINT trial. This is from Yeager et al., found in JAMA Cardiology. This is longer-term all-cause and cardiovascular mortality with intensive blood pressure control, a secondary analysis of a randomized clinical trial. So this group, in essence, wanted to know. So the SPRINT trial, as I'm sure we're all familiar with, it's, I think, to me, maybe the most important trials in my recent practice. They looked at intensive blood pressure control versus standard blood pressure control in patients that had elevated cardiovascular risk. And that elevated cardiovascular risk was clinical or subclinical cardiovascular disease or chronic kidney disease. It had a great larger cohort of sort of older patients. So it looked at patients that were at higher risk and looked at whether intensive systolic blood pressure control versus standard improved mortality. And turns out it did. But the trial, as you recall, was ended a little bit early. It was like in 3 years and change because there was such a benefit. They're like, okay, we know the answer now. We should probably stop doing this. And the authors of this particular article wanted to sort of extend things out and see how we were doing well after the trial and sort of extrapolated out data and wanted to see if the benefits of mortality, of all-cause mortality and cardiovascular mortality persisted even after the actual study period. The trial participants were linked to the National Death Index, and so they looked at those numbers between 2016 and 2020, so missing out on COVID, which probably would have thrown things off a little bit. And then for the blood pressure, they extracted the longitudinal data of systolic blood pressure from 2010 to 2020, and they only had a smaller cohort of patients they were looking at this with, but still a good chunk. I mean, close to 3,000 patients that they were looking at. And so basically, the cardiovascular mortality benefit was seen in the intensive arm between 2 to 5.5 years, and then it sort of attenuated throughout the observational phase. The systolic blood pressure, interestingly, also went back to around 140 for both groups, whether they were the intensive arm or whether they were in the standard arm.
So, Paul, you're saying basically the blood pressure just if you take your foot off the gas or the brake, the blood pressure just went right back up in the treatment group. And then the benefits seem to just disappear by that 5-year follow-up point.
I think you nailed it. I think that's why this is important. I think this probably reinforces that the results from SPRINT were real, because when the blood pressure was well controlled, you saw the benefits, and when it was less controlled, those benefits went away. So I think
right.
the bigger takeaway from this is that, and there's lots of reasons for why it went that direction. Like this, these patients returned back to their clinicians immediately after the SPRINT trial and were no longer in the study, so they weren't getting these very rigorously protocolized blood pressure measurements. They were not being seen every 2 months. They were, their treating physicians may not have even had the same targets as the SPRINT investigators. So there's lots of reasons why the blood pressure may have gone back up. But in any case, I think this makes an argument that tighter blood pressure control reduces mortality, and that it's just, I think, an argument to be diligent and sort of, as you say, keep your foot on the gas pedal as you're treating these patients with systolic hypertension.
And was there actually a difference between the observation follow-up period and the actual trial period in the number of antihypertensives that patients were on? Do we know, or do we not have that data?
The data may exist. I do not recall it if it does.
Yeah, I did not come across that either. I wasn't digging around deeply in any supplements, so that may exist, but that wasn't something I read about.
Are you wondering if more medications were added on or if medications fell off? What was your question about that specifically?
Yeah, kind of like that. It seems likely that some medications probably fell off in the follow-up period. But
if they're no longer getting free boutique ARBs, right, then yeah, exactly. I think it's a fair point. No, genuinely.
I think as spending most of my time in primary care right now, it's just, and Paul, maybe you find this as well. I think that oftentimes there's just so much inertia, and then sometimes patients aren't believing their blood pressure is really high. People are really hesitant to add on extra medications. And I just feel like if we ever get to a state where there's constant monitoring of blood pressure, like we talked about on the AFib episode recently, Paul, that may help people, self-monitor, self-regulate, and be more adherent because they'd be more aware of it. I think it's a tricky problem to treat. And with all that support in the SPRINT trial, it's not surprising that, you saw benefit when it was actually controlled. But even then, they couldn't get it down to below 120. Let's remind ourselves. It's hard to treat blood pressure.
It's hard to treat blood pressure. And it's the absence of symptoms makes it, I think, especially challenging. It's hard to convince people that it's super important until something catastrophic happens. And I think it's going to be sort of hard to move that needle particularly, I think.
Well, fortunately, Paul, we have a really easy trial to interpret to end the show today. Just nothing, no controversy about this. I didn't see anything about it on the news. And who better to talk us through this than the great Dr. Nora Taranto? So, Nora, do you want to tell us who wrote this article and tell us about it?
So Brett Auer and Al wrote this article. It's the Nordic Study Group, Nordic meaning the Nordic European Initiative on Colorectal Cancer. And you definitely
pause for one moment. Paul, how do you rate the name of this study group here?
I mean, research is hard, but that's an intensely lazy acronym. That is, they should be ashamed of themselves. It should have gotten zero traction until they worked on that.
All right, Nora. So you said your article, the Nordic trial. Tell us about it.
Indeed. So the Nordic trial looked at the effect of colonoscopy screening on the risks of colorectal cancer and related death. The trial results were just published in the New England Journal of Medicine in the end of October. And the group looked at whether or not colonoscopies, and specifically invitations to colonoscopy screening, would decrease the risk of colon cancer as well as the risk of colon cancer related mortality and overall mortality. There have been many studies looking at the effect of colon cancer screening on the risk of cancer and the risk of death, both colon cancer and overall mortality. But many of these have been either cohort studies, so not randomized control trials, or they have looked at screening modalities besides colonoscopy. And colonoscopy is one of them.
I was going to say, Nora, this was very surprising to me. Like, I just thought, I was like, oh yeah, colonoscopy, there's got to be tons of randomized trials just showing that that's like our best. And then you find out that there's not any, which is, surprising. It's a very common test.
Yeah, it is surprising, especially I think in the United States where it's the most common modality. I would say I recommend it to my primary care patients. I don't know about you guys, but and perhaps this has changed a little bit in COVID actually, but I think that's kind of has historically been the go-to screening modality here. Though that may not be the case elsewhere. And so the study actually looked at populations in Nordic countries, as you might have guessed, in Poland, Norway, and Sweden, looked at almost 85,000 men and women between 55 and 64. And they compared a invitation to screen group with the usual care group, and kind of importantly, the usual care group was not getting invitations to screen for colonoscopy, or was not getting colonoscopies or colorectal screening testing during the.
Is it true, Nora? None of the patients in either group had undergone screening, right? That was one of the
Correct.
exclusion criteria. And the reason they were able to do that is because it's just not standard practice to invite people for screening colonoscopies in those countries, which was, again, I was like, what? I thought this was just like, I thought everyone was doing this.
Yeah. And I think, correct me if I'm wrong, any of you, but I think that some of that has changed over the last 15 years. So there are more colorectal screening protocols in several of these countries, but they did not overlap with the population that was studied in this trial at all.
Mm-hmm.
So it was a pragmatic trial, which was designed with the intent of trying to reflect as close to real-world clinical practice as possible. And the groups were this invitation to screen and usual care. And the invitation to screen group had a lower risk of colorectal cancer at 10 years. Now, that didn't translate to a lower risk of colorectal cancer-related mortality or a lower risk of overall mortality. And so that's kind of an important discrimination there. It was an 18% lower risk of colorectal cancer diagnosis over those 10 years. And the number needed to invite of the screening test was 455 individuals to prevent one case of colorectal cancer. So, Rahul, I'm curious, kind of what do you make of this number needed to invite and just this study and its results overall?
I have a couple things to share with you all, and I just want to say I welcome any questions from the group, from listeners. This is kind of a difficult thing to decide what to think about, especially when this kind of flies in the face of what many of us have just kind of assumed was a robust evidence base, kind of like fluid resuscitation, pancreatitis. So this. The primary outcome in this study was the risks of colorectal cancer and related death. So, colorectal cancer incidence, there was a reduction with screening. Colorectal cancer death, there was really no change. So, this was not a overwhelmingly positive study in the sense that we saw a mortality reduction that, you might expect from colonoscopy. So I think for the sake of discussion, we can call this a negative study. Okay. Now, what we have to deal with and what we have to kind of confront is, do we think that this is the truth, or do we think that there are reasons that this could have been a falsely negative study? And there are some signals for causality in the study that, I want to be cautious not to overinterpret, but I do think might provide some valuable learning for our listeners. So there does look like in the adjusted per protocol analysis that there was a dose response between the degree of uptake of colorectal cancer screening with colonoscopy and the effect size of reduction in colorectal cancer deaths. So overall, only 42% of the people in the intervention group actually ended up getting a colonoscopy, which is a big drop off between the number of people who were, emailed or who were snail mailed an invitation and who ultimately got a colonoscopy. Okay, so that's an important source of bias towards a null finding. But then within the 4 countries that were included, the rates of uptake differed quite a lot, from a low of 33% of people in Poland to a high of 61% of people in Norway. And so in the adjusted per protocol analysis, the effect size on colorectal cancer mortality was bigger in Norway than in Poland, which makes me wonder, is this a reflection of the fact that if you do more colonoscopies, the beneficial effect is able to become apparent? So that's one possibility. Another possibility is whether or not this study was long enough for the benefit of colorectal cancer screening to kind of become apparent. And we know from studies of fecal occult blood testing in colorectal cancer that it takes a long time, like more than 10 years, for the mortality benefit to become apparent. So I'm kind of waiting for the final analysis of this study, which I think is planned for 15 years after randomization, to kind of, answer that question. And was this a long enough time horizon to really see a difference? The last thing I'll say, people who want to believe that colonoscopy is, what we should be doing, I think are prone to gravitate towards the results of the per protocol analysis, which did suggest a reduction in colorectal cancer death. So it's just important to remind all of us kind of what the per protocol analysis means and what that is. So that is looking at the effect of the intervention among people who got colonoscopies. Okay. And the important thing to be aware of with that is that when you only look at people who got the intervention as opposed to the entire study population, the intention to treat population, you are kind of sacrificing some of the benefits of randomization. And I don't think it's controversial to say that this study is vulnerable to post-randomization confounding and selection bias because of the fact that only 42% of people in the intervention group ended up getting the colonoscopy. And this was sort of a result of this being a pragmatic trial where consent was done after randomization, in contrast to how randomized trials are usually done, where you consent a patient and then randomize them. So, consent is kind of an important process. That's where patients are kind of told all about the risks and benefits of a study intervention. So, I have to wonder, would uptake have been higher had patients had the opportunity to undergo consent before randomization? So this is one of the trade-offs we make with pragmatic trials. It would be impossible to study something like this at this scale by individually consenting every patient. So it's a trade-off we made. But I just think it's important for people to know, it is important to, when you're counseling patients, have some estimate of what the effect might be in the individual. And it's really hard to extract that from a randomized controlled trial where not a lot of people did the intervention under study.
So you're saying like the randomization or the consent process, the patient's essentially getting like education about why they may benefit, kind of like what we do in clinical practice, where we're saying, hey, I think you should get a colonoscopy because we can find cancer or polyps that could become cancer. We could find cancer early, and that would potentially benefit you. So it's more a little bit like what happens in practice. And if you just get this thing in the mail, you may not read it, and I think that's one of the main limitations to me of this whole thing.
I do also wonder how the evolution of like communication modalities in medicine would affect the results of this. Kind of what with so many more patients having access to pretty much real-time communication with medical teams and professionals who are doing community health outreach and saying through the phone, just through email or through electronic medical communications. We recommend this kind of doing behavioral nudges, like how now the data would change.
And I was going to say, Nora and Rahul, I wonder what y'all say, because this is relative to your comment, Nora, that some people think of this study as more of a efficacy of implementation of a screening program, as opposed to necessarily like, should we be utilizing colonoscopies for colorectal screening? But just like, are we evaluating the efficacy of this invitation? And what you all think about that. And my second comment is, I just want to say, as somebody of Polish descent, Poland is not a Nordic country, so I'm not clear what happened there. But I do love that Poland was included. I'm just like unclear about our definitions of Nordic countries. But also
want to feed that back.
Yeah. But also do want to hear, Nora and Rahul, your thoughts about this kind of evaluating more of an implementation population-based screening than necessarily our colonoscopies, the best colorectal screening test.
Yeah. There's a great paper in the New England Journal from 2017 by Miguel Hernan on the kind of ways to do per protocol interpretations of pragmatic trials. We can link to it in the show notes. And a point that they make that I think is really kind of understandable and helpful in this situation is an intention to treat analysis in a pragmatic study is really testing the effect of treatment assignment in a particular trial, not the effect of the intervention itself. Because, the effect of colonoscopy screening could be different in an individual patient who has a precancerous polyp and is going to get colon cancer. And we always have this tension between trying to take average treatment effects from large randomized trials and translating them into the individual patient. So I think you're right, Era, that this was a test of the invitation to colonoscopy screening in this pragmatic trial, and whether or not we can really generalize to the individual patient. We're going to need information beyond what was provided by this study.
Along the lines of generalizability, I guess, and I don't know if you all know the answer to this or have gotten deep into this in your reading. I wonder how sure we are that this population is comparable to the population in which we serve too. You think about sort of the modifiable risk factors like tobacco use and obesity and alcohol consumption. And I just wonder if this is sort of a one-to-one correlation with our own patient population too, and if it's directly applicable or not.
Yeah, I mean, I don't have the content expertise on this that I'm sure many of our listeners will. So again, I invite knowledge if anyone has any. But one concern I would have about kind of abandoning colonoscopy as the standard screening modality on the basis of this study is that, you might expect that to have ramifications for equity of care in the United States, where we've got a bunch of different populations of varying risks. So I think we would have to sort of think, long and hard about who our patient population is and what the sort of baseline risk is for lesions that might be missed by strategies that don't involve colonoscopy.
I think we're going to need a Hotcakes rating for this, Nora, because I think we are at the end of the show. And so will this be practice changing for you, and Hotcakes rating for this one? What do you think?
I think I'm going to give it 4 because it is a really important trial. But I don't think it will change my practice. And I'm excited about several other trials that are in the works, specifically some that are comparing the different screening modalities, colonoscopy and FIT testing.
I think those will be helpful to have. And I'm not ready. Like we said, this was more of a implementation of a screening program that it was convincingly looking at more so than the actual how well colonoscopy works. And as Paul pointed out, different population. So I think we've done some great work tonight, everybody. four articles, lots to discuss. Hopefully the audience learned some things, and I know I did. So I think it's time, Paul, to go to an outro.
Terrific. Will do. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
It was anyone's to take, but you claimed it. I totally give you that. Get your show notes at thecurbsiders.com, and while you're there, sign up for our mailing list to get our weekly show notes in your inbox. Plus, twice each month, you'll get our Curbsiders Digest, edited by the great Dr. Nora Taranto, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we want your feedback. So please subscribe, rate, and review the show on Apple Podcasts or now on Spotify. You can also send an email to askcurbsiders@gmail.com. A reminder that this and most episodes are available through VCU Health for free, CME at curbsiders.vcuhealth.org. I wanted to give a special thanks to all my wonderful co-hosts tonight for helping to write and produce this episode. The technical production for Curbsiders is done by Podpaste. Elizabeth Proto runs our social media. And finally, Stuart Brigham composed our theme music, which we all love. So with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Rahul Ganatra.
And I'm Dr. Ira Kryzhanovskaya.
And I'm Dr. Nora Taranto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.